As you all know, the International Forum for Promoting Homeopathy is conducting regular webinars since last 1,254 days. And we have 3 sessions in a row every day from 7 to 10, 7 to 8. We have our Hindi session. 8 to 9, we have an international session in English. And from 9 to 10, we have a local language session in Malayalam. So what the purpose of these webinars are really to promote homeopathy, to make homeopathy towards the people, towards the layman, so that more and more people know about what is happening with homeopathy, as well as we are connecting doctors from different parts of the world. Already doctors from 65 countries have presented various papers in this forum, and as you all know that doctors from India, eminent doctors, almost all came to our forum and made excellent presentation in Hindi as well as in our English session. That means that we are really connected with one another, and this is something great as far as homeopathy is concerned. So let us introduce our guest of the day, Dr. RUCHI MEHTA, MD, and she had completed a PhD in homeopathy itself. And she is working as an assistant professor, Department of Obstetrics and Gynecology, Homeopathy University, Jaipur, Rajasthan. And today she will be talking about a single blind trial of estrogen 3C in managing menopause. That is a research presentation. Already we have a lot of research presentation in this forum. Yesterday also we have a wonderful session from Dr. Suraj Singh Bahadia. And today Dr. RUCHI MEHTA is also here to present a research paper. So this is something great as far as homeopathy is concerned. We are having lot of research fellows in homeopathy field. So we proudly welcome Dr. RUCHI MEHTA to this session. Doctor, you can present the session for the next 45 minutes, and then we will have a discussion. So if your paper is a big one, we can divide it into 2 parts and we can go ahead in that way. So please start sharing your PPT and everything. We welcome once again.
Namaskar to all my senior eminent homeopaths and sharing the board with you. Sir, today I want to talk upon understanding researches in homeopathy. Nowadays, NCH is also working upon researches and homeopathy, because research is what we have to re and search. Re means again, and search is to find out something. To find out and establish a new fact, or to research, find out a new conclusion. This is a systematic investigation into a study of materials and sources in order to establish a fact and research a new conclusion. My topic for PhD was single blind trial of estrogen 3C in managing menopause. So this was my basic study, and why I took estrogen to be the part, because many people they have a estrogen deficiency when they reach menopause. So my basic aim was to study estrogen in homeopathy, which was available in the market, whether will this estrogen help the females who are suffering with menopause, because when the menopause is there, females do take estrogen, a materialistic dose, which harm them for a very long period of time. Even we see post malignancies, post menopausal malignancies, and when we take the history, we find out that some people used to have estrogen therapies during their study. So my basic concept to take the topic was this, and I wanted an answer. So I conducted a research on it. Then the problem of a research should be identified by the investigator, is a kind question and hypothesis which verifies the question, and the hypothesis gives an attempt to answer the question. This is what I feel that research is. What should be a characteristic of a good research? Good research has systematic approach. We should approach systematically and capture the data. Researchers need to practice ethics and code. You have to take a permission from the ethical committee. You should see whether a research is harming the person or not. Is it a perfect research, or it might harm a person? We cannot, for example, many a times we have students with they work on asthma, and when we ask if the patient gets aggravated or there is some other respiratory disorder with it, will you be able to manage it, or you continue with homeopathy, will you give it a chance for allopathic or any other method? They simply say no madam, we, because they are many a times they come after BHMS MD, so MD students, they say no ma'am, we'll go with homeopathy. I don't believe this. You should have an ethical approach to your study. A PCOS patient could be a controlled study. Controlled study means giving placebo to a patient. 15 patients to placebo plus 15 patients with homeopathy. That could be patients from cardiovascular diseases, diabetics. You cannot go with only placebo. So you have to have some approach. So you should have an ethical behavior. The analysis is based upon logical reasoning. I should give a logical reasoning, and both inductive and deductive logic should be involved in it. The real-time data knowledge is derived from actual observations and natural settings. The observation should be absolutely what you felt, because homeopathy is feeling the patient in himself also. There is an in-depth analysis of all the data collected, which we are nowadays using biostatical approach, and it creates a path for generating new questions. While I'll be dealing with my research, I'll tell you how in the end we gave an path for new questions, which I want my students, my juniors to answer them, or in future, if I get the time, I want to go with those researches again. Accuracy is one of the most critical aspect of research. You should be very accurate. You have to go with the statistical analysis. There are biases. You shouldn't be biased upon. For example, you should go with laboratories provided and controlled environment when you are dealing with some titers like thyroid profiles and all that. You can even use instrument calibrations. All the things should be used, and you shouldn't be biased that we shouldn't use that. Research is in homeopathy. Homeopathy is more scientific and logical, and it applies both inductive and deductive logic. But still, with changing time, the followers are still trailing with the most same way of treating homeopathy. They don't want to change things with it. Environment has changed, people have changed, thinking have changed. Homeopathy is based basically on mental understanding and mental symptoms, but with changing time, people have changed their behavior. The way they react, the manipulation, presentation, everything has changed drastically. For example, when I sit in OPD, we take the case. A patient goes with the MD scholar, gives an absolute different case. When we ask the patient, they give us an absolute different answer. So people try to manipulate us. So homeopathy may we should understand how the patient is manipulating, how much the patient, how are we going to deal with the manipulation. Environment is changing. When the homeopathy was, there were no electromagnetic radiations around us, but nowadays we are surrounded with electromagnetic radiations that is also going through intrauterine behavior also. So researches in homeopathy are more important and are more needed than anything. It is very important to modify according to changing trends and try to research with homeopathy. This is an example of my thesis with which I'll try to explain how researches could be done with homeopathy. This is a single blind trial of homeopathy. This is a single blind trial of homeopathy of estrogen 3C in managing menopause. Now, when this is the thesis, the title is the very most important and it reflects the whole study. So it should be comprising the whole understanding of the study. As my title is single blind trial. Single blind trial simply means that I know what medicine I am giving. My patient doesn't know what the medicine they are given. For this, we go with coding. I write on my prescription E3C, and my dispenser knows that the doctor has prescribed E3C, and it is an open prescription. When the patient goes to other places and he shows E3C, other dispensers generally don't come to or the other patients don't come to know, patient doesn't come to know. So this was a study which I knew it was the medicine 3C. and I took estrogen because this is the hormone that is basically deficient, and I wanted to study. And basically, I was acting or taking care of the menopausal age group. So I hope my title is crystal clear. And the second thing, the study should be clear and concise, and it should have less variables. If I take variables like in a post hysterectomy female also I was studying this, or in female who was on HRT, then the variables would have been increased. So I just wanted to reduce the variables. And every study which you are doing, we need not be a very big study. We see patients who take, students who take actionable gas or a very big broad disease, headache is a very big, it is a symptom, it is a very big sorry, it is a very big topic. So we should take concise topics. More concise the topic is, more easy you are there to answer. You can elaborate your study to an extent, but if you concise the study, your study will be easy with less variables. So you need to answer in a less format. Now, research questions. My research question was whether homeopathy can help the patient suffering from menopausal complaints by the use of estrogen 3C. So this was what the question I was trying to answer. I wanted an answer whether the homeopathically prepared estrogen could be helpful in that or not. So this was my basic question. Then when you are asking a question, this should be a primary aim. Now we draw a hypothesis. What is an hypothesis? We draw a null hypothesis. Null hypothesis is negative hypothesis. So what is an hypothesis? Establishing research problem is a highly creative act. The research question should be questions which you want to answer. Now we come to an hypothesis. Then von Dendrer of 1973 observed that hypotheses are suggested problems, solutions, which are expected as generalization or proposition, which we want to answer. To understand hypothesis is a kind of guess. What happened? Is a kind of guess or conjecture about the possible effect of certain postulated relationship between two or more variables involved in a problem. So this is what hypothesis says. Hypotheses are of two types: primary null hypothesis and an alternative hypothesis. So null hypothesis is also known as no difference hypothesis or a negative hypothesis. This simply means that there is no effect of the medicine, there is no effect is expected to happen after taking medication in our cases. So this is null. Nothing is going to happen whether you take the medicine or not. Whereas the alternative hypothesis could be 1, could be 2, could be 3, but the alternative hypotheses are probable solutions of the research questions. Like the homeopathic medicine estrogen 3C will produce or help the patient suffering with menopausal complaints. Or if I would have taken a placebo control, then I would have said, or a constitutional control, that is I am giving a group with constitutional drug and a group of people I am prescribing estrogen 3. So then I can make an alternative hypothesis 1, hypothesis 2. So as I have made an hypothesis that estrogen 3C is not going to ease out menopausal complaints. Whereas my alternative hypothesis was the basic question need to be answered by the study is to find out, is homeopathic estrogen 3 is effective in dealing with menopausal complaints or not? Now in this, on the basis of menopause rating scale. So it is very important that you rate your study when you are doing a research or a study. You should it be on any gold scale. That is, as I have used menopausal rating scale, we have other scales also, quality of life scale. Even VAS scale could be used when you are a beginner, because if you are not going to do researches in homeopathy, we will not find answers. We don't have documentation, and then we don't stand on the same platform with other pathies. Then when you have made a topic, we have designed a title, we have asked a question in ourselves that this is the answer, this is the question we need to answer. I have made a hypothesis, zyada se zyada maximum what's going to happen, my medicine is not going to act or it is going to produce some symptoms. So symptoms could be, it is going to ease out my complaints. This is what I am taking in our mind. Always remember the thesis, a research study need not always be positive. It might be negative study also. Like I take a medicine, I say Nux vomica is not going to relieve the abdominal. Like we have Nux vomica is good for GI symptoms. I can even ask, could just, it could be a good or bad. There are few medicines which are not acting when you find it in a clinical research. So you can always research, say I want to find an X medicine is effective in hemorrhoids or not. It could be a positive research or it could be a negative. Negative research means that at present scenario, this medicine is not acting with us. So we can always have a negative study. So need not to be worried if the study is going a negative answer, but it could be a positive, good. Negative is also very good. Aim and objectives of the study, the aim. Now, when you are writing an aim, you are having one single aim. My single aim was whether estrogen is going to help the patient or not. And objectives could be many, to establish the usefulness of estrogens in treating menopause, to find out frequently occurring symptoms and most relief symptoms during the drug of estrogen. So I had many objectives. You can have further more objective. In which socioeconomic status, this is a very common problem. Since menopause is a problem, every female on the who has have puberty is going to achieve, whether it is going to be surgical menopause or it is going to be a normal hormonal or physiological menopause. So menopause was a very common, so it was not related to a socio-economic group, to an age group. So we didn't took that, but you can take then objective. You are studying a rhinitis, you can take this, which socio-economic group is more affected with gastritis, rhinitis, and you can always take that which age group is more affected with so and so disorder. So we can always take more than one objective, but aim is always one. You are having one research question, your answer should be one, your aim should be one. You should have one lakshya in your life. Now we have epidemiology. When we are writing a study, we are doing a study, I should be aware about the prevalence of the disease in my area, in my state, in my country, across the globe. We cannot take a study at our level that which is very rare, 1 in 1 crore people. So no use of taking such study. It should be very prevalent, or it should be a study which have prior. Some people have, you can always take first time. My study was first time when I did a estrogen 3C trial, but it should be prevalence. The disease should be a prevalent one, no, not a rare disease. Prior to the study, we need to understand its prevalence and problem in the society. This could be the prevalence of the problem in a particular area, like in my place where I practice. The big problem with me was I was not able to find good patients, ample number of patients with menopause, because many of them have met with a surgical menopause. They get their uterus removed or hysterectomy done at a very early age, because I am practicing at my rural area. But since menopause is achieved by everyone, so we can study that. Along with prevalence in the state and country, is this disease only prevalent to your place, or if it is a prevalent in your state, that stage or your population nearby, it is okay, fine, you can take a study. But at least you should have an idea that is it an epidemic or a pandemic. So like COVID was a pandemic, so we can have an idea, and you should have an idea. So epidemiology is very important. Now, when we talk about materials and methodology, because any study need to be having its own materials and methodology, then you have like I had the study setting and study duration. My place was OPD of MPK Homeopathic Medical College Research Center, Jaipur. My study period was 12 months, follow-up was for 6 months, because this is a protocol for 3 years PhD. You can even have a bigger study, you can have surveys, you can have shorter studies, you can have pilot study. Pilot studies means before doing a big study, I am doing a small study. I am taking a small group of people, say 15, 30, 20, and I do a study upon them. Then I come to a conclusion that my medicine, X medicine, is very effective in dealing with so and so problems. So I can give a bigger, this is a pilot study. So we can do a study, we can do a survey, we can do anything. But this was my study because it was my PhD study. Now, study design was as an interventional, prospective, single blind trial. The other types of study design could be a retrospective, Retrospective study means how many people in my population or my known population has underwent hysterectomy and for what reason. This was a retrospective. Hysterectomy is being done. Then I want to know how many people have had hysterectomy. So this could be a retrospective design. Introspective, prospective means I'm seeing a future of it. Then interventional, because I gave the medicine. It could not be an interventional study because I was doing a retrospective. Medicine was already given, treatment was already being done. I just found out the population, the reason to the hysterectomy. That would have been a retrospective, backward study. Now sample size, because standard effect of this was, and standard effect was 0.4 at 80% power. The sample size was a 50 patient. The sample size could be bigger, but my limitation was that. And when I talked with my senior gynecologist, they have said menopause is a thing that is achieved by all the females. And what is true for 10 female is true for 100 female, is true for 1000 female. So you can do a study if you are having less number of patients also. So we took sample size of 50 patients. Now, inclusion and exclusion criteria. When you do a study, you should know whom to include in the study and whom to exclude in the study. That is very important. I took the patient age group between 45 to 60. As you can very well understand, menopause is to be achieved in these ages only, because prior to it is surgical intervention, and post 60 it is useless. So inclusion criteria is very important. The patient coming with 3 or more complaints out of this is a screening. We took a screening because there was no readily screening form available. As for tuberculosis studies, what we do is we do go for a chest x-ray. Any person who is having a chest x-ray positive is to be considered for tuberculosis. So similarly, we do a screening. When the people are coming to us, I took these 5 symptoms primarily of menopause, and I did if 3 symptoms were there, this was a screening form. If the patient was having 5, it was group, but minimum 3 was supposed to be there. These were hot flushes, sexual dysfunction, palpitation, mood disorders, and menstrual irregularities. And only those patients were who they gave their consent for the trial. If they would have haven't given the consent for the trial, we would have not taken them. Then exclusion. What patients is to be excluded are also very important, like post-hysterectomy cases were not included in the study. Females with any systemic diseases like diabetes mellitus or insipidus or hypo or hyperthyroidism were ruled out. Patients with severe hypertension, in which systolic was above 160 mm of Hg and diastolic was above 100 mg, was not included. Patients suffering from diseases like tuberculosis, carcinoma, and other illnesses. This was to simplify my study and decrease the variables. If I would have included any of them, the variable would have been more. So when you are doing the study for the first time, or you are initiating in the subject, you want to start the researches, then you should have less variables. Lesser the variables, easier to study. Patient with all the criteria but not willing to participate were also excluded because they might not come for the regular follow-up. So that could be a problem. Now, study tool was case record format, which we have specially designed, and menopausal rating scale, which we'll discuss later. Then the menopausal rating scale is a health-related quality of life scale and developed in response to lack of standardized scales to measure the severity of symptoms. So this was a scale that was being formed to, because it was health-related quality of life scale. The menopause rate is formally validated scale according to the requirement for the quantity of life instruments. This is a validated. When you are doing a study, you should always try to use a validated study. If you are going for a research purpose, even if you are at your clinic, you should try to use validated scales. There are n number of validated scales available. Some are paid, some are free. The menopause rating scale consists of list of 11 symptoms of complaints. Each of 11 symptoms contains scale 0, that is no complaint, or up to 4 scoring at the basis of severe symptoms. And these are all perceived by the females herself. And she has to tick. the name of the medicine intervention was, name of the medicine was estrogen 3C. Repetition of doses were done according to the severity of symptoms in the patient, and the medicine was obtained from GMP certified company. You should always take the medicine from a certified company. That was Material Research Laboratory, which was having this number. And the medicine, my study was in 2018, so the medicine was manufactured in 2015. Even the batch number of an interventional tool should be included, because the drugs many a times are very and the drug was prepared according to HPI and USHP, that these are the pharmacopoeias. Outcome assessment. How am I going to assess my study? The result of treatment of each patient is assessed separately on the basis of improvement of the symptoms individually using a menopause rating scale. Each patient is assessed and improvement is evaluated using the formula. This is a formula you can get everywhere. Baseline score upon after and baseline score before in 200. This is the way we take out the, when the patient who has maximum improved in all the symptoms, that is 75 to 100%, we'll say it is the maximum improvement. Moderate improvement is between 50 to 74%. Mild improvement is 35 to 49%. And the patient who showed no significant improvement were 24, less than 24, and no relief to the symptoms were status quo, that means 0%. Thankfully, I didn't have 0%, any, not even 24. The data analysis were assessed as per the defined result criteria, assessment criteria. The data analysis was carried out by data sorting method, classification by tabulation, and interpretation by histograms. This is the way we present the data. The scale was filled by the patient or the attendant if the patient was illiterate, as per the changes she felt. When I was filling the scale, and I was new to this, so I skipped the step, and the step could be the step that to break the biases we could have done before, after. I could have taken a scale intermediate or on every visit of the patient. This would have given me a better result. But since it was something which I missed, I don't want any other to miss it, that a scale can only be before after, but it can be used as inter between also to assess the progress of the patient. Data analysis on the basis of before and after menopausal rating scale was computed, and we applied parity test on before and after scales. But we can always take inter between also, that like I took the scale on first visit, then on second visit, then on third visit. I can have that also, but I missed it, and I took the before after scales to find out the outcome. Now the observation and results were there. The result were all the symptoms on menopause rating scale were ameliorated, but no adverse effect was noted during the study. Estrogen 3C is affecting in dealing with menopausal complaints. This is what I got an answer. And vaginal dryness was the most relieved of all the symptoms, and hot flushes was the least relieved symptoms. You may ask, when it is a estrogen study, when it is menopause, then the hot flushes were the first things to go when we give a constitutional remedy or many things. But maybe because of my geographic area, because we are in Rajasthan, and the female is not able to distinguish whether she's having a hot flushes, and we have summers approximately 8 months, approximate 8 months. So many a times females are not able to differentiate whether it is a hot flush or she's feeling hot because of weather. But vaginal dryness was the most relief symptom, which gave me a confidence, because estrogen deficiency produces vaginal dryness in females. And so this was the most relieved of all the, when I did the study, I told you the conclusion was miles to go with estrogen 3C, that few questions were still needed to be studied. Which is more effective, constitutional drug or estrogen 3C in dealing with menopause? So this was something a question which I left, and I need others to answer, or if I have the opportunity, I like to get it answered by myself. Or higher potencies of estrogen need to be evaluated for menopause. I took 3C because O.A. Julian says the three C's are to stimulate the action of the higher are for suppression the. So I took estrogen 3C to stimulate the ovarian function and let the estrogen decline slowly. It was not a substitute. If I would taken a higher potency, it might be a suppressive mode. So still a higher potency of estrogen might have done some different results. Now this is a case. This is a single blind trial. This is a case of my patient which we need to discuss. She came to me complaining only of vaginitis. And 2 years back, she was apparently well when she started complaining of irregular menses. And since last 12, 13 months, she hasn't menstruated. And 3 months, since 3 months, she was complaining of vaginitis, but she came after 3 months saying, maybe because I am old, I am having this problem. She felt dryness of vagina with constant itching followed by burning. So this was what she was having. Pain in both the legs, aggravated standing was her second complaints. Then and for long, as if the leg will break down, she was feeling. When I inquired about her menstrual history, the age of menarche was 13 years. And her cycle was when she was having, this is the question we used to ask, the quantity was scanty when she had her last cycles towards last. It was fluid and partly clotted, bright red and hard to wash the stains. It was non-offensive, it was bland. Nothing specific she felt before menses, during menses or after menses. And LMP was not remembered because she said it was a far back. I don't remember the exact date. Now, the other questions we need to answer are, what were the changes in the menstrual cycle in her early years? It was very profuse. Before menses also it was profuse. After marriage also, but after pregnancy it started declining. And age of menopause was 47 years, what she said. And the complaints associated with menopause, which we were talking upon screening, they were hot flushes, senile vaginitis, and senile pleuritis with the concomitant of dryness of the skin. Now, obstetric history was total pregnancies were 4, 3 were full term, and 0 was one abortion was there, and stillbirth was not there. Childhood death was 0. All 3 are alive, 2 sons and 1 daughter. This is about her obstetric history. She had all 3 overall full time normal vaginal deliveries. They were all institutional deliveries. Purpurium was normal. Weight was absolutely normal. Alive, normal. But one of the last she had an abortion. She took medicines for abortion and had a abortion at 1 month only. So as when we talk as a patient as a whole, appetite was 3 and was satisfied. Thirst was 7 to 8 liters of water, normal according to temperature. Desires was nothing specific. She said, I didn't have any desire, no aversions, food desires, food aversions. But when we inquired about urine, burning after micturition, daily 8 to 9 times, and night she was going 3 to 4 times. She was non-diabetic, which we have already did the test. Stool daily once, but constipated and ineffectual urge. She used to say, I am not able to empty my rectum, and I feel as if something still remaining. Thermally, she is chilly patient hai. Bathing habit is regular according to temperature, non-offensive, non-staining on covered path, perspiration. She had no history of addiction, and vaccinations was all done as per her understanding. She was having sound, refreshing sleep for 6 to 8 hours. She didn't had any history of suppressions. As we discussed the mental, she is the eldest among 4 brothers and sisters. Childhood, as far as she knew, had all milestones on time. Relationship with the siblings, she had a loving, caring attitude towards her sibling. Education, she was average in study, got married early at the age of 19 years. She graduated after marriage and was supported by her husband. And husband is really loving, caring, supportive person. She's a very cheerful lady, and same today. She's today also very cheerful. Her mother-in-law was no doubt very strict, and she was quite afraid because she was very timid personality. Then she loves her kids a lot. She has a good family. Present mental, she's very cooperative, cheerful lady with morbid fear of major illness. She had a fear of major illness. Impulsive, nervous in temperament. She is quite cooperative. But her husband was saying she is turning moody nowadays. Frequent mood changes are also seen, changing, weeping to be happy, dreaming, not specific. Now, sexual history, she is feeling dyspareunia due to dryness of vagina, though she is quite active sexually and had excess of sexual desire previously. Family history is father was hypertensive and died, mother was also died, grandparent normally died, and the siblings are all healthy and alive. I know maximum of them. Why did I select estrogen? Because of hot flushes, sexual dysfunction, palpitations, and mood disorder. General conditions was approximately she was fine in every sense. On examination, what we found out was there were senile changes in her genitalia, and per speculum also senile changes were there. Per vaginal, no abnormality. Uterorectal examination, no abnormality, and no per rectal examination. Breast, both bilaterally symmetrical, atrophic changes in both the breast, with no discharges from the nipples and no changes in the nipple. None of the lymph nodes were enlarged on either side. Now, this was the score which we were having before, menopause rating scale, and this was the scale after. So you can see before she was having hot flashes 4, that was very severity, even heart discomfort, palpitation, unusual awareness or was moderate. She was having that. She was not having much sleep problems, depressive, moody. She was depressive mood, feeling down on set was severe as per her husband. She said I was fine, but her husband says she is severe, has mood changes. Anxiety was there, especially of any morbid fear of any big disease, grave disease. Then mental exhaustion was there. She used to feel very severe tiredness. Sexual changes were there, and bladder problem was there to a moderate extent. Dryness of vagina was very severe, and joint muscular pains were also very severe before. But after the study, hot flashes which were previously very severe became moderate. Heart discomfort was almost gone. Sleep problems she didn't had also. Depressive mood also changed to mild form. Then anxiety and restlessness was almost gone. Mental exhaustion was mild. Their sexual desires and sexual perversions were also mild. Bladder problem was also mild. And dryness of vagina, which for her basic was almost gone. And joint discomfort also mild. This was the study of my patient. And you can see we took give estrogen 3C BD twice a day for 7 days. For she was called for every 7-day follow-up. And last, when she came to me, she said she's quite ameliorated in pain in legs, decreased, no senile vagina. We cannot find that much dryness. So she was enjoying her sexual life to a point, but she had said she has more of the sexual appetite now. So this was the case which we were having. And this was all about how to do a study and why should we do a study. This was a case because estrogen 3C was a rare drug. Nobody studies estrogen 3C. So we have other drugs also in our materia medica which are rare. We have progesterone, we have other medicines also that need to be again restudied in a different aspect and related to a normal human physiology. Even pituitary is there, ovaries are there. There are many drugs which are still there. I'm trying to study ufuroinum with PCOS and folliculinum with PCOS patients in my personal OPD. I just want to know whether folliculinum or PCOS is able to help out the patient with PCOS in a long term, because when we went for a CME, There was a doctor, eminent doctor, she said polyculinum is a very good drug if given for a long period of time for PCOS. So I just wanted to verify whether it is. So this is an, see, research is an aptitude. You developed an aptitude in your upcoming years during your clinical to answer your own questions. Nobody is going to ask you a viva voice question, but we have to answer our own questions, and that makes the research very authentic. We need to do researches in homeopathy because we have the questions, we want others to answer it, and it's an individual experience. I might have given an estrogen 3C, got the result. Somebody might have given lachesis, graphitis, pulsatilla to this patient, moreover pulsatilla, and would have got much better results. During my study also, I found out few patients during my study period, they were fine, but they came again with the same problem, and then we gave them the constitutional drug, and the constitutional drug ameliorated for a very long period of time. Even the patients are towards cured only. So this is something I want to share with this. These were my experience with a very new drug, and I wanted to share on the bigger platform that many a times we have drugs with us, but we don't have an approach towards it. There is a drug known as placenta, and it is for menorrhagia, a very good drug for menorrhagia, but I was not able to have that much patience from on which I could have done the trial. So if anybody has such an ample amount of patient for menorrhagic conditions, they can go with it. So this was all I wanted to share with you all on a bigger platform. I hope I have given maximum I could. We have further cases also, and this is all for the day from my side. Thank you, sir.
It's thank you, Dr. Ruchi Mehta, Professor. Really a very good session. You really proved that homeopathy is one of the best system in the world that can work in menopausal area, and that your scientific evidence-based study really proved once again that this is a fact that homeopathy is as science as any other science. It is the biggest science, and Dr. Hahnemann has predicted this thing some 250 years back, but nobody thought that this much of scientificity was there in in his philosophy. So this kind of studies really gives confidence among doctors as well as our junior students, as well as the public who have not have any idea about homeopathy. But when they see all these kind of evidence-based study by you people, definitely more and more people will approve homeopathy as the scientific system of one of the best system in the world. And as we know that there is no change in our philosophy. Yeah, our philosophy is a fixed one. Our theories are fixed, but still our medicines are still the same as we used in 250 years back. But a lot of medicines are being proved by nowadays. And the symptoms you choose in this session, particularly the menopausal symptoms, the of hot flashes, the bleeding,
Irregular menstrual cycle.
irregular menstrual cycles, as well as the palpitation. And as you all know that most of the women at menopause get more fatty and beautiful, I must say, because during the time, because of the hormone activity, some people were ashamed in their childhood that they are in the youth, they were very slim. But when you see somebody at the age of menopause, they look so beautiful. So these are the things I would like to add to your session. And anyway, we hope you can present some more cases in the study, particularly the estrogen 3C. Nobody might have used, but definitely we will start using this. What are the other potencies, whether it is available in 6C, 300, 230, 200, like that, ma'am?
Sir, we have 3C and 6C available. It is some Calcutta-based company which is giving us the medicine. So only 3C and 6Cs were available. I asked them for 30 also, but they say we'll get it if they can get it. But the study was my study was limited to 3C. I also want to explore the further potencies like 6C, 30, 200, maybe higher potencies. But as far as my literature, what I study is the higher potencies do suppress when they are given in sarcodes are given a higher potency. They do have a suppressive action. For that fear, I didn't use higher potency. I limited my study to 3C only.
What's your opinion on repetition? Whether you use these three estrogen as an intercurrent remedy or as a remedy itself, as a similar
No,
one?
sir, we give it in BD twice a day, or even I gave afterwards also because it was my topic and I had the medicine. I still we are dealing, and 3C is giving me good results with even thrice a day. Even I am giving it TDS.
That means that when you get a patient with these above symptoms, you just give only estrogens. See, no laxatives or any other constitutional remedy, as we used to say. But being a research person, you have to stick on a particular remedy, of course. But that is the only thing that you are doing, or whether in tandem you give some other medicines in the future.
Sir, when I was doing research, I stick to it. But nowadays, I give 3C thrice a day. Then when the action is exhausted, or the patient is saying now I have only hot flashes left, or I have this complaint left, then I give a constitutional remedy as an intercurrent higher doses, and it generally cures the patient suffering with menopause.
Okay, thank you, madam. Now let us go to the discussion. Dr. Sridhar Kurupu, Dr. Manisha Sir, Dr. Ramprasad, all are waiting for you to interact. So let us begin the session with Sridhar Kurupu, sir. He was a research assistant director at CCRH.
Madam,
Hello, sir. Yes, sir.
Dr. RUCHI MEHTA, it was very
Haji, sir.
excellent. So I also done in Kottayam also. I was to the coordinator for that the menopausal syndrome. We took it for 5 years, and it was very good effect. That there we saw that the lacusis, that Netromor and sepia,
And
etc. I'm
pulsatilla.
not remembering completely. That I am
Sir,
also.
even the pulsatilla has given research, and I study your research paper when I was doing my estrogen 3C study. So lacasis, natramure, pulsatilla, even sepia was there in your study.
Okay, madam. Anyway, it was excellent, and this section was that your study was very good. That we
Thank
have
you,
so
sir.
many limitations. Of course, sometimes we may know that there is a lacusis or sepia or natrum or pulsatilla may be indicated, but you cannot give because there is a protocol. You must have to observe the absolute protocol. I know, because I was last so many years, more than 30 years, I was worked as in the CCRH. So I know even the doctors also I worked. So I know the difficulties. Sometimes we are tied up with that even indicated medicine we cannot give because there is a strict protocol from the headquarters. And anyway, I was done my BHMS from Jaipur, that the Padsar was the principal, Jitendra Padsar,
Yes, sir.
and his brother was my colleague. And I also spent about 2.5 years that in Jaipur and done my BHMS from there. Okay, so it was a very good institution. And one of my friend, Dr. Sinha, was there. And at present also there is one, Saxena, who is working as a laboratory technician. You may know him. And he is one of my intimate friend. That, okay, anyway, please come with case records and the same subject, rest of the case record also you can present. Anyway, so many other medicines also, what you said, the uparobinum and so many other medicines,
Folliculinum.
polyculinum, that the so many other medicines, that it is a very good action that I observed, that it is very good. You can have a study on that also, because you got that facilities, because it is attached with your hospital. So it is easy for you to, and also you can be a guide and you may have so many other students, postgraduate students and PhD students you may have. You may be the guide, one of the guide there. So you will get ample opportunity. So it will reach to some good like that, or some good new research. That is the need of the hour. Anyway, I congratulate you with my heart.
Thank you, sir.
Thank you very
Thanks
much.
a lot.
We wish you all the best.
No,
Come
thank
again
you, sir.
with such a very good paper. It is not easy to do the research in homeopathy, and according to the protocol that others will say in homeopathy, it is not correct, that protocol, but it is too difficult to do it. I know, I experienced that. Thank you very much. Wish
Yes,
you all.
Thank you, sir. Thank you, sir.
now it's up to Dr. Manisha, sir.
Good evening, ma'am.
Good evening, Manish. How are you?
Ma'am, very good. I hope you recognize me.
Yeah, I recognize you, Manish. He's one of my students.
Oh, wow, wow.
So,
मैम
doing what?
ऑब्वियसली आपका सेशन तो हमेशा ही अच्छा होता है, तो आज भी अच्छा ही था। मैम कुछ नहीं,
Thank you.
कंप्लीट हुआ है जस्ट, तो जस्ट फोकसिंग ऑन माय क्लिनिक एंड द रेस्ट ऑफ द कॉम्पिटिटिव एग्जाम्स ऑफ एमओ एंड ऑल।
See, when you are only at your clinic, we have n number of, you can even use modified Nanjo's criteria to observe the effect of your medicine on the patients. And this could be a research paper in the upcoming years. You have to ask the patient whether my medicine put any effect upon, that is a modified Nanjo's criteria. You can use it as a regular thing in your clinic, so that you can create confidence among yourself and to your patients also. Otherwise, we have other gold scale, but even some common criterias or common scales could be used. Quality of life, VAS. These are the scales you can use at your personal clinic also.
Ma'am, I am collecting some data, but obviously since my clinic is new, so the patients obviously the footfall would come with time only, na? So yeah, I am collecting the data, and obviously when the sample size would be fine, then I think I'll publish that.
You can go with pilot studies, small studies, and all the best for that.
Thank you, ma'am. And thank you, ma'am. आपका session, ma'am, literally the session was very good, and I want that, ma'am, आप Hindi के session में भी आए, please.
Okay.
Ma'am, obviously
Dr.
साइनी सर के आप contact में हैं, so I would like that आप Hindi session में please आए. Okay. Thank you, ma'am.
Okay. Thank you, Manish.
Dr. Manish is one of our moderator at Hindi as well as in English session. He is doing excellent work in that field. He is really working hard for this international fund for promoting homeopathy, to promote homeopathy. Thank you,
He's
Doc.
my student, sir.
We are really proud to
I'm
have.
his proud teacher.
Yes, definitely you can proud of him. And we are also proud of him also. Okay, now it's up to Dr. Rampari sir to say a few things.
Thank you. Good
Thank you,
evening,
sir.
everyone. Our congratulations, Dr. Ruchi Madam. Very nice presentation.
Thank
Good
you, sir.
lectures. Good
Thank you,
lecture.
sir.
Menopausal syndrome and many kinds of deals medicine, sepia, pulsatilla. So very thank you. Very, very thanks.
Thank you, sir. Thanks a lot.
Definitely, we need this kind of research work to bring homeopathy to know people about all these things. What are the things that really happens with homeopathy? And now I think Dr. Himata Baswal want to speak to you. Okay, if any other person want to speak, you can raise your hand. Please unmute, ma'am.
Hello, ma'am.
Hello, I'm Lata. How are you?
Good evening, ma'am.
Good evening.
I'm fine, ma'am. कैसे हो?
बस first class.
बहुत
Okay.
अच्छा था मैम आपका सेशन.
Thank you. Thank you. Thanks a lot, dear.
Okay.
Dr. Hemilala, you're working, you're practicing at Rajasthan, somewhere else. Where you're practicing?
Yes, sir. I'm assistant professor in Gujarat.
Yes, definitely. You can also present some presentation in this IFPH. If you are
So
interested.
she's also my student.
Oh, that's good. So you can share her number so that we will contact her. Anyway, we are really to have such a beautiful session in this evening, and tomorrow also we will have another session. Every day we have international session in English at 8 p.m. and we have a really good sessions are going. And yesterday also we had a session, about research. So, as you all know that the first paper presented about COVID research work was here in this platform by Dr. Amar uh, uh, and Dr. Anil Khurana, who presented the research work on COVID and arsenic alpha-30, in which he has presented that 99.8% result in those conditions. So we are lucky to have such presentation. Hope some more presentation from Dr. RUCHI MEHTA and all others in this forum.
Sure, sir. We'll try our level best. Thank you, sir.
Now I invited Dr. Mars from Malaysia to say vote of thanks to this session. Dr. Mars, please unmute yourself and you can say the vote of thanks. Mars, are you there? Yes.
Yes, thank you so much, Dr. RUCHI MEHTA, for the wonderful sessions. Yeah, I've been following the sessions very closely, and I look forward to having more sessions like this in the future. So, on behalf of IFPH, I would like to express my utmost appreciation for such a wonderful sharing. Thank you once again.
Thank you, ma'am. Thanks a lot.
Tomorrow we will have a session from Dr. Veena, and she will be talking about why homeopathy science should be studied. This is a different subject. She always come up with some philosophical presentations, and definitely that will also and will be an entertainer for us in the evening tomorrow. Hope all you will be there with us at the same time. We are once again thanking those who participated in the session from different part of the world, as well as our guest, Dr. RUCHI MEHTA. Thank you all. Good night.